Hi, I'm Dr. Howard Jack West, and I'm a medical oncologist with a particular focus on thoracic oncology. I'm an associate clinical professor in the medical oncology division at City of Hope, and I also lead a program called Access Hope that works on remote consult services there. And I'm based in the Los Angeles area. I'm happy to welcome all of you to this multidisciplinary tumor board on a series of provocative lung cancer cases.
Hi, I'm Michelle Ginsberg, and I'm a director of cardiothoracic imaging at Memorial Sloan Kettering Cancer Center. And I'm also vice chair for education in the Department of Radiology, also at Memorial Sloan Kettering. And I'm also a professor of radiology at Weill Cornell Medical College, which is across the street from Sloan Kettering in New York City.
Hi, everyone. I'm Suresh Ramalingam. I'm a professor of hematology and oncology at Emory University and the Winship Cancer Institute. Like Dr. West, my focus is also on thoracic oncology.
Hi, I'm Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University in Atlanta, Georgia.
Hi, everybody. My name is Cliff Robinson. I'm a professor of radiation oncology at Washington University in St. Louis, and I am the chief of the Cardiothoracic Radiation Oncology Service and director of clinical trials.
This is a 79-year-old current smoker, significant smoking history exceeding 100 pack years, an oligometastatic adeno, left upper lobe, 6 centimeter, a little over 6 centimeter, and a solitary metastasis to the left adrenal gland. Found on a workup for weight loss and persistent cough, biopsy positive, no mutations, PD-L1 negative, brain MRI negative. We'll review the imaging, but we'll see that it shows that single left adrenal gland lighting up. 15-pound weight loss over 6 weeks and a performance status of 2 that I might argue would be relevant in speaking to our enthusiasm about an oligometastatic approach. Past medical history is COPD, prior appendectomy, current smoker. And actually, we don't have the images to look at here. So, picture's worth 1,000 words. I'll just have to do 1,000 words. No, but the details are: it's a 2 centimeter left adrenal lesion, lighting up SUV 13.8, and nothing more distant. So, I would say start with Ram. What are your thoughts here? Is this someone you would, if they came into your clinic first, would you send them for consideration of any local therapy, A, from the beginning, or B, is this someone you'd be thinking that after a few months you'll likely send to someone for local therapy?
Sure. I think that the question of local therapy in oligometastatic disease is a real one, and it is being studied. So the NRG trial that's looking at this question, the LU002 trial, is something that we would highly prioritize for a patient like this. And that would involve initial upfront systemic therapy. And after you've given them 4 cycles of therapy, they're randomized to systemic therapy with SRS versus, radiation versus systemic therapy alone. At the outset, I would start with systemic therapy. And for this patient, the molecular workup, I would want to make sure that this included broadened NGS to cover all the genes for which there are FDA-approved targeted therapies. We see that EGFR, ALK, ROS1, and BRAF are negative, but we want to make sure that it was tested for MET, it was tested for RET, and also for, what am I missing here? There are 4. There are at least 7 genes, ROS1, ALK, EGFR, BRAF, MET, RET, and NTRK. Those are the 3 that we would want to be tested for. And once you exclude a targeted therapy as an option, then I would proceed with systemic therapy. In this case, PD-L1 is negative. So this would end up being chemo plus IO approach, or potentially a ipi-nivo approach as well in this particular situation.
Cliff, would you say that I would be concerned. I would surmise that somebody with a marginal performance status, significant weight loss, this is someone who, imaging notwithstanding, I would be less enthused. I would be more concerned about this person not as likely being a major beneficiary of local therapy. Do you share that view? Are there data to speak to that?
Yeah, so as was mentioned, this is an area of active investigation, and is so highly investigated at this point, and lots of little trials, that I think it makes it extremely confusing to figure out how to manage a patient properly in this environment. We're bordering on loss of equipoise with these multiple randomized phase 2s, but we have to remember that those are highly select patients under very specific conditions. Someone like this, I think there are certainly some people, if they had a higher performance status and they were younger, some people might consider doing definitive chemoradiotherapy and then coming and treating the adrenal. Generally speaking, we try not to favor that approach. I think there's a tremendous value, because the patient already has systemic disease, in understanding how responsive they're going to be to their overall systemic therapy. I think passing a litmus test to demonstrate activity and then demonstrating that there could be value in local therapy is extremely important. And so that's our favorite approach at our institution. So I absolutely agree. I think starting with a systemic therapy, reevaluating them, seeing how they're doing both from a performance status standpoint, but then also from an imaging standpoint, is extremely valuable. And as you mentioned before, I think we can think of that as a, quote, diagnostic tool in the assessment.
So I'll summarize by saying that for this particular patient and scenario, we would favor first as broad molecular testing as we can get, including, if it was limited to the ones that were listed, that NGS-based testing for a few additional clinically relevant markers for which we have other targeted therapies, that would be worth pursuing, just to confirm that we're talking about the best systemic therapy. But we would recommend starting with the best available systemic therapy, and someone who's PD-L1 0, that's often going to be chemo with pembrolizumab. You could consider nivolumab and ipilimumab, but start with that, look for a response, and then have the option available in somebody who's doing well clinically and radiographically with confirmed still just residual unifocal or very limited disease. You could follow up with local therapy, but wouldn't lead with that, especially because the weight loss and performance status would lead us to speculate this may not be someone who is likely to fare as well, but worth leaving that option open.
And the one thing I would add to that as well, just is that the location does matter. So I think a single left adrenal metastasis is a more favorable oligometastatic situation than, say, a quote, single intra-abdominal retroperitoneal lymph node, or a single cutaneous met, which are clearly a different type of metastatic spread for a lung cancer.
Yeah. And just for my own edification, and I would, just for brevity, I had learned from a mentor who did this for years before oligometastatic disease was a thing, but he felt that bone metastases just never do well. Is that your view, that oligometastatic to bone is potentially a different animal, less favorable than brain or adrenal?
Absolutely. Yeah, I think they can still do well, but it certainly is not the same as an adrenal or a single brain met.
Right.